Hello. Thank you so much for the honor and privilege of speaking to you today. My research interests pre-pandemic were the aging immune system with regard to respiratory infections and vaccinations, not just because of the acute, but also because of the long-term consequences of having an infection. So anytime I get invited to something that has senior in the title, I get really excited because you are my people. And what I do, to quote Brian Adams, I do for you. So today I'm going to tell you a few stories about my experiences as my lab pivoted its work to the COVID pandemic, and also how I accidentally or inadvertently found myself having two jobs. One is being a communicator of science, and the second actually being a scientist. And so today I've sort of framed the talk with some science for my colleague who wanted more science. Well, here comes my friend, we're going to do some immunology. And I'm going to talk about how understanding or having a deep understanding of some of the immunology behind vaccines really helps deal with vaccine hesitancy. Because when you can speak with confidence about how these vaccines work, then uptake is inevitably higher. So this is a curve of some deaths ending sort of in January of our pandemic. And I've sort of framed today's talk about what I was asked about and when. So as you know, vaccines sort of came at the end of 2020, or so they started their rollout. Now, in what I call the before times, when we were all living in this really scary world where there was a lot of death, and especially in our long-term care communities, we were living through lockdowns and trying to make good decisions. Vaccines were the hope that would get us out of this. And as a hopeful message, the questions I always got looked like this lovely young lady who would say, Dawn, please tell me how vaccines work and how they're going to get us out of this pandemic. And so when I was speaking to the public or the media, there was such optimism and enthusiasm for the power of science. So let me tell you how vaccines work and where they go. And for this, I want to start with a misconception that is still to this day really led to a lot of confusion about how good these vaccines are. And that's the confusion about, do vaccines go to your blood? Do they circulate around? Do you make spike proteins that you can shed in your saliva? Is there going to be off-target effects to your other organs? Where does a vaccine go when it gets injected into your heart? Now, I don't know, are any immunologists in the audience? Good. So good, I won't be speaking to the converted then. So one of the things that happens is people don't understand is vaccines we pick muscly bits of you because there are lots of immune cells in there that sample, but their first route is not to go into the bloodstream at all. They go to the lymphatics. So the lymphatics is like a highway for your immune cells. It's what they use to travel, and they go to the lymph nodes. And some of you who've been vaccinated may have had swollen lymph nodes in your armpits or whatever, the one that's closest to your injection site. And so what these immune cells do is they pick up the vaccine ingredients and they travel to the lymph nodes. And the lymph nodes are where there are billions of immune cells. And so it's a great place to start an immune reaction because all the ingredients are there, everyone's there. So there's all these wonderful names, you don't have to know any of them. But just know that the lymph node is the first stop for these immune cells. Now, before I move to the next slide, I want you to reflect on your vaccine journey and think about when you had your first dose, when you had your second dose, and when you had your third dose, and if any of you had your fourth dose. And I want you to think about when you felt the worst. Number 2, okay? Think about that. Let's actually do a show of hands. So reflect, when did you feel worse? Was it your first dose? So we have 1, 2, 3, 4, 3 first doses. Was it your second dose? Okay, was it your third dose? And fourth dose. Okay, so this is really important. And I want you to see the shape of this curve would have been first dose, second dose, third dose, fourth dose. Okay, remember that. All right. So this is, again, this was if there were some immunologists, they could reflect back and be like, oh yes, look, TLR7, I thought it would be there. But for the rest of you, I'm going to draw you a picture about what actually happens with your immune cells when you see this vaccine. So as you will, most of you will have got the mRNA vaccine. So mRNA, the M stands for message, right? The message of that. You can't see it? Okay. Okay, so the message for the mRNA vaccine is that it sends a message to make what's called the spike protein. The spike protein is on the outside of the virus. However, in my little diagram here, you're going to see some green S proteins. And what I want you to look at is where they are. They are on the surface of those immune cells. The messenger RNA makes a message to make the spike protein because that looks like the virus, but it also includes what we call an anchor to stick it to the cells itself. It does not float all around your body. It does not get to all your organs. It sticks on those immune cells that make them. And those immune cells then show that stuck S protein to a whole bunch of other immune cells which start their thing. The second thing that happens with that spike protein that your mRNA encodes is some of those immune cells will chop it up into a million pieces and show different kinds of immune cells, little itsy pieces of this. So I share this very complicated diagram with you because one of the most common misperceptions I see is that the spike protein's bad for you and it gets all through your body. It's not bad for you. It's stuck like glue to those immune cells or chopped into a million tiny little pieces. There is no vaccine parts floating around your body causing mischief. All right, so let's go back to the first dose, second dose, third dose, fourth dose question. And this is like in every textbook that I've ever seen in immunology about what sort of rates of the immune response look like. In your first dose of the vaccine, you get a little bump. You get everything started. You start making those cells. Now to make that all those immune cells, to get everyone into the lymph node and to find the right mixing and matching, it takes about 2 weeks. So as you will remember, there was a lot of you're not protected until 2 weeks, you're not protected until 2 weeks. That's because to get everyone to the same party takes about 2 weeks. And even then, it's important to remember that your immune response loves to forget things not remembered. And the reason it forgets things is because everything you eat, everything you breathe, all the dust from your mask, everything you touch, you need to ignore from an immunology perspective. Otherwise, your gut would be inflamed all the time from all the microbes that you live there or that you eat. Your skin would be constantly inflamed. You wouldn't be able to breathe. So the immune system is actually programmed to forget much more strongly than it is to remember. And for this reason, for some of our vaccines, if you only ever get 1 dose and for whatever reason you don't finish the rest of them, you actually have to go back and start from the beginning because your immune system will have forgotten. So 1 dose does not give you very long protection because that immune response is not very high and it doesn't last very long. Now the second dose says, wake up, pay attention. You've seen this before. You need to see it again. Get your act in gear. And furthermore, all the hard work of finding all the exact right immune cells and getting everyone working together has already been done. So that second dose can work a lot faster and a lot more robustly. And if you look at the slope of those 2 lines, what you'll see is the slope of that second line is higher, faster, bigger. Your immune system is really primed to look at differences. It's not the absolute amount of an immune response, it's the speed at which that immune response is generated. And so that second dose is a huge ramp up, and all that immune response causes a lot of inflammation. That includes the sore muscles, the malaise, the headaches, the feeling unwell. It tends to be with dose number 2. Now, of course, humans are humans, and so there's a lot of variation there. People, for example, who've already had an infection often feel really poorly after they've got their vaccine because they're really getting effectively a 3rd dose. And some of us, it takes a little bit longer for our immune system to ramp up, so the 3rd dose can be a little bit stronger. But in general, when you have a really bad go of your vaccine, rest assured that subsequent goes will not be so bad. Once you've had the worst one, you're not going to have them like 3 years from now. You're not going to go get your booster and feel like death warmed over again. So that's the only piece of good news I ever get to give people on any of my talks. Okay, so now we know how vaccines work. And now you can speak confidently to anyone who has concerns about, the vaccine circulating through their body. It can be like normal milk. It's anchored to the immune cells that make it. It's chopped into a billion pieces. Go talk to Dawn. So even in these glorious times, early in the pandemic, when people respected immunologists and were excited about vaccines, there was still that girl in the audience with her sour little face saying, yeah, but I'm young and healthy. Why would I even need to be vaccinated? And I call them the Yabbas because it's no matter what sort of information you provide, it's always yeah, but. Have you thought about yeah, but? So how do you deal with the Yabbas? And I'm going to tell you a little story and show you some data. So one of the studies I'm involved in, it's a study of retirement homes and long-term care communities, 23 homes across the province of Ontario, 1,200 or some odd research participants who've been kind enough to donate their blood to us after each dose of the vaccine so we can understand and help make recommendations about when they should get the next dose. These are some data I'm showing you about after the second dose. And so as you can see, there's a lot of dots. We've literally over 1,000 people in this study. And we sort of partition people into the red zone, means that there's no detectable antibodies. We can't find any antibodies. Red zone's bad. Green zone's awesome. Green zone is the equivalent of a healthy young person at peak immunity. So if you're in the green zone, you're living life to the fullest. Yellow zone is always a little bit worrisome because we don't really know what level is protective and what isn't. The blue bar is the median. So half the people are above half the people. And so these data we put together right at the 6 to 8 dose. And this was sort of just at the beginning of the Delta wave. And my colleague, Andrew, and I, we put the data together, we were looking at it, and he said, Dawn, right now, you're telling me half the people in our study are in the red zone, half. And I was like, yeah. And we called each other the next day, and he said, Dawn, I didn't sleep very well last night. And I said, Andrew, I didn't sleep very well either. He said, what are we going to do? I said, I think we're calling everyone. And so we did. We talked to Alison here, who got speaking to the Ontario Science Table, and Public Health Ontario, and PHAC, and the COVID Immunity Task Force. And we were like, guys, the Delta's here, and this is what this looks like in our community. And I call it our week of outreach because we were on the phone and on Zoom meetings with anyone who would listen. And thankfully, we were able to convince them to expedite a third dose. So that was awesome. After our week of talking with healthcare and our week of bad sleep, we went and talked to our study participants. We do these Zoom meetings with all the homes and all our partners all the time. And so I was presenting these data and I was super nervous about it because I was about to tell people who, like, 50-50 chance you've got no antibodies and almost no protection against this virus, right? At this very minute, 50-50 chance. But at least I was able to say, but good news, in 2 days, third doses are coming to your home. So good news. And as I was presenting this data, one of the women in our study who's in her late 80s, living in long-term care, just seeing this graph, I think I tried to explain the fact that the red zone was a bad place to be, said, you know what? I don't think I'm gonna get a third shot because I've never had the flu. I don't get the flu shot. I've been exposed to lots of kids in my life. I just don't think I'm gonna get COVID. And I was like, I had this weird moment of like, we are doing this study because you have lost a quarter of your companions in the early part of this wave. You have seen the death and the disability that this has caused. We are doing this because we need a tool to keep you safe so you can have a life where you're not locked in your room and you get to see your grandkids. Like, I was just absolutely blown away. But this speaks to a really fundamental ground truth of this pandemic, which is nobody is good at assessing their own health or their own risk at all. Now, like I said, We were effective in using these data. This is right when the third doses began. The Delta wave was just creeping up in long-term care. So this is the number of cases. It was just creeping up. Those third doses came, it went down. And we were just so relieved for about a month and a half until Omicron hit. I'll tell you some stories about Omicron in a second. But at least we were able to take our study and our policy to practice and help mitigate some of these effects. So just to show you what the third dose looks like. So we've just sort of finished analyzing some of these data. Again, you've sort of seen this graph already with the second dose. We did have a number of people who did refuse the 3 dose. So we've got now another time point on there, the 8 to 10 month time point. And you can see that those antibody levels do decline. Third dose was really good. You know, you get a big bump, but I also want you to look at the fact that there is a significant number of people who will always be in that red zone. And those people might be on immunosuppressants. They might just be, you know, on the very extremes of age. There might be some other medication or health condition that we don't fully understand. But it's important to make sure you have all your doses, because unless you're in one of our studies, you don't get to know where you sit in that graph. And I don't want you to take the risk. I want you to get those doses to get yourself up into the green zone and provide yourself the best protection you can possibly have. So back to self-perceived risk and health versus actual risk and health. I think we've heard all our speakers today discuss what parts of this pandemic has been difficult for them. And for me, the most difficult part of this pandemic has been the serious lack of empathy for people who aren't in robust, good health. I have found it very hard when someone says to me, yeah, but how many of those people in the hospital have pre-existing conditions? Because honestly, I don't care if you have a pre-existing, you know what your pre-existing conditions are? Being a man. BMI over 25, welcome to North America, everybody. You know, being not white is effectively a risk factor. So don't give me this, you know, othering that those people in the hospital are somehow there because they deserve this. I don't buy it. And I'm tenured and I have strong opinions, in case anyone wants to know. But other issues are, you know, just a misconception about what your immune system can and cannot do for you. You know, some people just think that they're going to be one of the lucky people. Their immune system's going to get them through this. And they might be right, but they also might be wrong. And I can tell you, we've been studying with great interest who does well and who does poorly. And we have been unable to find out any reason why some people get through this with an asymptomatic infection and some people do not. Public messaging has been dismal. I still meet people who say they've got their 2 shots, they're done, they're young and healthy, they don't need a 3rd shot. That is not true in the Omicron era, but that messaging that booster shots are for sick people is a message that has unfortunately taken hold. And other people think, you know, they're just going to get the cold. Well, we've lost a lot of people in their 20s, 30s, 40s, and 50s. We're also seeing a lot of kids hospitalized. So your risk may be low, depending on where you're at, but you don't get to know that until you get an infection. So one of my major learnings is our self-perceived health and our perception of risk doesn't always match reality. Now, ironically, a lot of infectious disease people, myself, are like slathered in masks and haven't gone anywhere. So my perception of risk is probably a little bit over high, but anyhow. So let's bring you to the next part of the pandemic. Now we've got vaccines. They're being rolled out. There's a lot of enthusiasm. Canadians are being good Canadians and lining up to get their 1st and 2nd doses. Easy questions to answer for me, difficult questions for doctors to answer. And as well, we've also had an issue with some PR problems. So here I've got a picture of a lovely rheumatologist who's talking to his patient who is RA. And she is saying, you know, doctor, I've got rheumatoid arthritis or some other condition, and I'm on this medication. Is the vaccine safe for me? And the doctor, unless he's very confident in the principles of vaccinology, is saying things like, people like you weren't in the trials. We don't have any data. I don't know what to tell you. And as a result, there are still many people who haven't been able to get a straight answer about the risk of their medical condition or their medication that they're on from a doctor or a public health official. And as a consequence, there's this perception that because they have a disease that puts them at higher risk of COVID, that makes the vaccine less safe from them. And the reality is the exact opposite. I want that lady with rheumatoid arthritis at the front of the line, not holding back because she hasn't had a doctor been able to say confidently, we know that people like you and on medications do really well with vaccination and we need those. So one of the studies, 2 studies that I highlighted on this slide that I got involved in, even though God knows I did not have the time, were to help provide people answers that they needed because they weren't included in the trials. You do not put pregnant women in study trials, even though vaccination is extremely safe for pregnant women. And in fact, it's incredibly beneficial for them and their babies. But we started these 2 studies to sort of help people and to help them understand that the risk of disease does not make a vaccine less safe for them. Those are 2 fundamentally different elements of the immune response. And in fact, most people, if they're on an immunosuppressive medication, the concern is the vaccine won't work because it requires an immune response, not that it's unsafe. So bad public relations, you know, oh, the National Advisory Council on Immunization, you're killing me with your messaging. So, you know, great example. AstraZeneca is a good vaccine. It is, it's a very good vaccine, which has a slightly higher risk of a very rare condition in one population. And Canada is a fabulously rich country who happened to have one heck of a procurement minister who got us enough vaccines. So the decision was, we have choices, we have options. Let's just not use that one. Those poor AstraZeneca people thought they were unprotected, they were unsafe, they thought that they might develop some crazy health condition months or weeks or some clotting thing years in the future. The public perception was a disaster. Other questions that immunologists were not vocal about was explaining that mixing and matching your vaccines is awesome. It gives the immune system 2 different things to chew upon and think about. And so now you've got a broader immune response. The general public has still said, no, 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 no. I have to hold out for whatever I got first to make sure I get that second. Don't do that, mix and match. Pfizer is the best, right? For reasons I don't understand. There's insane vaccine brand name loyalty. And I'm going to show you some data that says for your demographic and pretty much all demographics, Pfizer is not the best vaccine for you. Aren't you glad you came? And also, if there aren't clinical, you know, we kept saying, trust the science, we're following the science, but Canada went really off script in that we delayed 1st and 2nd doses. The clinical trials for Pfizer were 3 weeks apart and Moderna were 4 weeks apart. Not because that made immunological sense. It does not, and I'll tell you why in a second. It was because they were trying to shorten the distance to get everyone protected as quickly as possible. But in fact, delaying a dose between the 1st and 2nd dose is good. About 12 to 16 weeks is what we recommend for every other vaccine in our formulary. And that's because it gives the immune cells enough time to mature and start making higher quality antibodies and higher quality immune cells. And so when you boost with that 2nd dose after 12 to 16 weeks, you boost the highest quality immune response as opposed to the 1st immune response. I like to say the immune response of middle-aged professors just get better with age. And that is also true for your vaccine schedules. So I just talked about that. So now I want to show you one of the studies we started to help healthcare workers understand why they were going to be okay. At McMaster and everywhere, we have a bunch of healthcare workers who were prioritized for the vaccines early in the pandemic. They got them really, especially the respirologists and the infectious disease teams. And they often were on this delayed dose, and they were really worried that this would mean that they wouldn't be protected. So we have 3 groups of Pfizer participants here. We have the people who got in the black, the 3 weeks apart between 1st and 2nd. The pink who sort of got 22 to 45 days, sort of intermediate, and then the extended delayed dose at 45 days. And so when we take their blood right at when they got their second dose, you can see that those green dots are a little bit lower because it's been a little bit longer since they got that first dose. But by 3 weeks, those jump up, and then at 3 months, they're higher, and even at 6 months, they're higher. And not only are they higher in levels, they're higher in quality. So delaying that first and second dose is actually a great idea from an immunology perspective. Immunologists knew this would be true, but the general public did not. Pfizer is the best, right? I got Pfizer, so I should always get Pfizer. No, don't get Pfizer. No, I'm just joking. Take whatever vaccine you can get. But here's some data to show you the difference in dosing. So older adults in general, we have special vaccines for. For example, we have a high dose influenza vaccine, which has twice the amount of the immunogen as the one we give to young people. And we do that because the aging immune system just needs an extra kick, a boost or kick. And so the Pfizer vaccine includes 30 micrograms of RNA. The Moderna one includes 100 micrograms, so about 3 times, more or less. Here's our long-term care folks. And you can see that this was right before they got their third dose. We have people who got Pfizer, and you'll see that about half of them are in that red zone. Moderna, a little bit higher up, and then there are only a few people who got a mix and match. At the third dose, what you see is we have a group who got Pfizer, but look at that group who got Moderna. That most of them are up in the green zone, and there's fewer in that red zone. The Moderna vaccine is effectively the high dose influenza vaccine. It has extra ingredients, extra kick. And on our recommendation, the National Advisory Council on Immunization and most public health units have now said that they're going to use Moderna for anyone over 65 at that high dose, that 100 microgram, whereas younger people get a half dose because they don't need that kick. We're just starting to look at the fourth doses, but almost all of our homes have now implemented giving Moderna in subsequent doses. So that's great news. We hope that those people start to get up into that green zone. So this brand name Loyal, how many people got at least one Moderna? I'll tell you, everyone in my lab was like, they're all young because, grad students are young. And they were all like, no Pfizer for me, I'm taking the Moderna. So because they were all involved in generating this data. So anyhow, as you move through your vaccination journey, I'd suggest that you get Moderna. All right, here's another PR disaster. Third doses are for sick people, right? Fourth doses are for sick people. And I have to tell you, no. In the Omicron era, we're all going to be looking at getting multiple doses. I don't think we're stopping at 4. I'm going to tell you a little bit about Omicron and why it's evil. So when we look at these antibodies in our studies, we look at 2 things. We look at quantity and we look at quality. In those early days, these vaccines, you didn't need a lot of antibodies. That's why we saw great protection after even 1 dose from those early pre-variants. Quality was all you needed. You needed a few antibodies that bound really well. The red is the spike protein, and the receptor binding domain is a little subset of that. So we measure all the antibodies that bind that whole spike protein, and they just sort of coat it. Imagine sticking gum on your house keys. You wouldn't be able to get that house key into the door, right? So they sort of, it's like a big gumball of antibodies. But in truth, for those early variants, all we needed is like 1 antibody to bind that 1 receptor binding domain, and it would just not be able to bind to our cells. It would just bounce right off. Now, when Omicron came along, all those mutations were in that one little sweet spot. So instead of having those really high quality antibodies, we had to really rely on just gumming up the entire spike protein. Really think about it like big hubba bubba gum all over your house key and trying to get into the door. You can get it in there, but it's going to take some time. So all of a sudden, we learned that in the Omicron era, it's not quality, it's quantity. And you have the most antibodies 3 to 4 months after your last dose, either your third or fourth dose. These are some data from the Ontario Science Table, which we've met the generator up. And basically, when Omicron hit in November, you saw that vaccine efficacies just went almost to nothing. And that's because most of us were well out of our 3 to 4th month from our last dose. But we started rolling out those third doses and we get a nice big level of protection again. We also have started to see that there is a little bit of creeping up again, which is why we're now doing fourth doses, because we're starting to see that that vaccine efficacy is falling, because I know I'm more than 3 months out of my last vaccine dose. But there is some good news, and I so rarely get to give good news. If you look back at this curve, you'll see that in the purple, getting a symptomatic infection is very likely right now, very, very likely. Going to the hospital and dying for vaccinated people is very unlikely. And what we've learned is that antibodies aren't the whole story. T cells or immune cells seem to be super important for keeping us out of the hospital. They pick up the slack when those antibodies can't do what they're doing. And here's the really good news. Those mutations in Omicron that mean those antibodies don't stick anymore, the T cells see a completely different part of the virus that has not mutated. So your first dose, your second dose, your third dose, your fourth dose have helped cement those T cells and really give you a lot of really good high quality T cells. And those are the cells that are going to help you stay out of the hospital and die. You need those antibodies to stop you from having any infection, but your T cells are there. They're prepared to step in when the antibodies fail, and they're going to keep you healthy. This is just some fancy pants stuff to show that T cells increase with second and third doses. And I haven't shown the data here, but I would also say our data shows that Moderna makes better T cells than Pfizer. I don't work for Moderna or Pfizer, but that's what the data says. Okay, so now let's just sort of wrap up this talk. Now we're in the Omicron era. And the Omicron era has told me that collectively, as a society, we are super duper bad at math. And I'm sure there's mathematicians and statisticians in the room who can verify what I'm about to say. We are not good at assessing this. Here's a classic case. In my science communication world, I talk to a lot of people who are who don't believe in being vaccinated. And they look at graphs like this and they say, well, there's as many cases in unvaccinated people as there are in vaccinated people. So clearly your vaccines don't work. And I say, let's look at the actual numbers of these cases and say, yes, it is true. There are, when we count the number of cases, a 2-dose vaccine does not mean you're not going to get a COVID infection right now. You can do, you will do. You're not going to die, probably you're not going to go to the hospital. But 90% of Canadians who are eligible have at least 1, if not 2 doses. And so the vast minority of Canadians who have had no doses are the ones who are taking up the proportion of these cases, and definitely these hospitalizations and deaths. There are lots of good reasons why people are not being vaccinated, and I don't want to assign blame. We've heard about the obstacles to getting vaccine from our last speakers. And a lot of that doesn't stem from not being able to, but it stems in things like societal distrust and the partisan nature of how we've made our medical decisions or how it's perceived that we've made these decisions. Social cohesion, trust in government, trust in science has really led to this really tragic distinction between those who do and do not get sick. And I think as we move forward, we need to think not just about the science, but we need to think about the human aspect, about how we make decisions. How do we teach our kids critical evidence? How do we combat social media and mistrust? This is my last slide about my personal learnings. As I said already, the hardest thing for me is the lack of compassion that people have for people who just desperately need to think it's not going to be them. It's going to be that person in long-term care who they don't know. It's going to be someone who's so incredibly sick they couldn't help but to die. That lack of compassion, the ageism, the ableism, the racism, I have found extremely hard to deal with. I've also learned nobody has ever been convinced by anything I've ever said if they read it in the printed word. There is no emotional resonance of reading the Globe and Mail. You know what? It's speaking to the converted. Where I know I've been effective at changing hearts and minds is when you can see me. And so videos, I think, are so important. You need to know that there's a person behind that social media account you're filling with hate. You need to know that there's a person who cares deeply. We need to have transparency about who pays us. I cannot believe how many people accuse me of cashing checks during the pandemic. What checks? I do get paid, but I haven't got paid any more during this pandemic. Where are these checks coming from? I've also learned that math, science, and social media literacy are core, and I have a lot of hope for children. Actually, I have a lot of hope that they are learning some of the skills they need, but I think we have to really think about education starting from very early on to help people understand perceptions of risk. Also, there's this thing called anchor bias. All of us hold on to the first thing that we learned. I still meet people who say they don't need masks. The scientists said in 2020 we don't need masks. Well, that's anchor bias. Messages also stick, so let's make sure it's a message with good resonance. The best vaccine is the one that's in your arm is a good message I can stick by. Well, if you're in this age group, you might consider not getting AstraZeneca unless you're at the highest rate, but that is not a message that is going to stick. So we need to think about having short, snappy messages that make sense to people, that resonate. So with that, I'm going to say thank you so much for your attention. I need to acknowledge my incredible team. The healthcare worker study came from my colleagues, Mylene and Daryl. Andrew Costa and I lead the long-term care study. Maggie Larche and I lead the immunocompromised study. Dr. Julia Denberg and I lead the pregnancy study. And I can't thank them enough for giving us this lovely debate. Thank you so much for your attention.